Welcome to Knowledge on the Go, the podcast brought to you by the PI Programs team at Vizient. I'm Shannon Hale, Senior PI Program Director, and your host for today's podcast. Our topic today will cover our recent Establishing a Structured Sepsis Performance Improvement Team collaborative. Sepsis is a life-threatening medical emergency caused by the body's extreme response to an infection. According to the CDC, in the U.S. alone, 1.7 million adults develop sepsis annually, and 1 in 3 hospital deaths are associated with sepsis. Joining us today is Dr. Lauren Williams, Manager of Quality Services at AHN Wexford Hospital in Pennsylvania. AHN Wexford Hospital recently participated in the Vizient Establishing a Structured Sepsis PI Team collaborative. Dr. Williams is joining us today to speak about her experience and work in that project. Dr. Williams, welcome.
Thanks. Great to be here, and please call me Lauren.
Thank you again for joining us. I want to start from the beginning and ask what drove you to enroll in the Establishing a Structured Sepsis PI Team collaborative?
We weren't satisfied with our outcomes, specifically with our SEP1 bundle compliance. Calendar year 23 overall, we were just over 56%. SEP1 is a process measure, but when we looked at our outcome measures, we also had more of a sense of urgency. Specifically, when we were looking at our 30-day readmission rates. For sepsis, they were just over 12% compared to our overall 30-day readmission rate of just under 10%. We had looked at some of the literature that wanted to learn from our colleagues across the nation in the Vizient network, and I'm glad that we did.
When you were first going into the collaborative, what were some of your initial goals?
I wasn't sure what to expect. I did go in with an open mind and wanted to learn from other people and shamelessly steal ideas. If other people were having a similar problem and they found a way to fix it, I could implement a similar strategy. We wanted to learn what other folks were doing because we did see a need for more real-time feedback when it came to SEP1 for our ED patients.
What were your takeaways from the collaborative?
The primary takeaway was that we were not alone in this work. On a more philosophical perspective, we go into healthcare to help people. We're all trying to get this sepsis thing right, and we're all encountering similar struggles. That was encouraging to know that there's many people facing the exact same challenges we were experiencing, and it was really nice to be able to partner with them, receive ideas from them on how to overcome some of the barriers.
Tell us a little bit about the work that you're doing around improving outcomes for sepsis patients at a community hospital. I'm interested to know, how did you decide to look at this and what was your approach?
We took a two-pronged approach. There was a lot of work that had already happened and been attempted prior to the collaborative. What we knew we needed was real-time feedback for providers, specifically in the ED. That's where the majority of our patients who were septic declared themselves to be septic, was through the ED. What we ended up doing was figured out our data source, which was a report through our electronic medical record, and looked specifically at patients who had come into the ED with a diagnosis of either a UTI, fever, sepsis, or respiratory symptoms. We eventually went on, once we fine-tuned the process of reviewing the chart, started adding altered mental status as the diagnosis that we looked at. Then our quality coordinator would pull those patients' ED diagnosis, their MRN, and then I would go in and review the chart, looking at did they meet severe sepsis or septic shock criteria, and then looking at the SEP1 bundle components, feeding that back to the provider and the nursing team as well, in instances where, let's say, the antibiotic was hung before the blood cultures were obtained, so that everyone received the feedback. And also would include our chief medical officer, who is an ED provider and has led a really strong culture around sepsis in the ED. Her expertise was also important. The other piece of it was education on the inpatient side.
You mentioned at one point that bandwidth and resources were some of the barriers in your work. How did you approach it and work to resolve those?
We had to pick it apart. I'm a nurse by background, so there's an element of prioritization that had to happen every day. We knew going into it that there were not going to be additional resources. We were going to work with what we had. I outlined what the process would look like in terms of review and feedback. Then I broke apart each step of the process and tried to streamline it, took a lean approach to it, trimmed all the fat. Our quality coordinator was the one to pull the information and put it into Excel. And then I would go in and review the chart. And over time, it took me a week or two to figure out the quickest way to get the information that I needed from the medical record.
A very strong process. I'm going to ask you the $1 million question. Any outcomes so far?
Yes, we've had a couple of wins. Our greatest win was for August. We had 100% compliance with our Step 1 bundle. We had never done that before. That was definitely a huge win. And we are seeing some promising results with our mortality and 30-day readmission rates. When we looked at 2022 and 2023, we saw an increase in our sepsis readmission rates. And so far for 24, we're seeing a downtrend. We only have data through August for readmissions, but that's promising. For 23, our mortality index for our sepsis patients, we were at 0.79. And thus far for 24, we are seeing a downtrend. It's slight, but it is still going in the right direction.
Those are some fantastic results. What are your next steps?
When we rolled out our sepsis alert, after that had an ask for a badge buddy. Those have been created and we're using that as an opportunity for additional education. SIRS criteria as clinicians. When I look at a set of vital signs, I might not see a heart rate of 95 as potentially being indicative of sepsis, but in SIRS criteria, heart rate greater than 90, respiratory rate greater than 20 are two SIRS criteria. So we are working to put little reminder cards of SIRS criteria around for our ED providers as they're evaluating patients.
This is great, exciting work with impressive results. Lauren, thank you so much today for joining us.
Thank you. Thanks for having me.
Our thanks to Dr. Lauren Williams, Manager of Quality Services at AHN Wexford Hospital, for sharing her story. And thanks to you for listening. For Vizient's PI programs, I'm Shannon Hale. Please join us for more knowledge on the go. Subscribe today, like us, and send us your comments at picollaboratives@vizientinc.com.